Squamous cell carcinoma, one of the most common malignancies worldwide, yet often underestimated. But why is that? SCC originates from the squamous epithelium and can arise in the skin, lungs, esophagus, and other mucosal surfaces. Today, let's break down its pathology, clinical presentation, diagnostic methods, and treatment options. Squamous cell carcinoma begins with uncontrolled proliferation of squamous cells due to genetic mutations that disrupt normal cell cycle regulation. But what triggers these mutations? Risk factors include prolonged UV exposure for cutaneous SCC, smoking for lung SCC, and HPV infection, particularly for oropharyngeal and anogenital SCC. Immunosuppression, chronic inflammation, and exposure to carcinogens such as arsenic also increase susceptibility. Histologically, SCC is characterized by keratin pearls, intercellular bridges, and atypical squamous cells. These features are key to its identification. High-grade tumors display significant nuclear pleomorphism, high mitotic activity, and invasion into deeper structures. Biomarkers such as p53 mutations, EGFR overexpression, and loss of p16 expression in HPV-negative SCCs play a key role in its pathogenesis. Now let's talk symptoms. The clinical presentation depends on the site of origin. Cutaneous SCC appears as a firm, scaly, erythematous lesion that may ulcerate. Have you seen something like this before? Oral SCC presents with non-healing ulcers, leukoplakia, or erythroplakia. Pulmonary SCC may cause chronic cough, hemoptysis, and airway obstruction. Esophageal SCC leads to dysphagia and weight loss. Advanced stages can metastasize to regional lymph nodes and distant organs. Diagnosis is confirmed by biopsy followed by H&E staining and immunohistochemistry. Let's look at the markers. SCC commonly expresses cytokeratin markers CK5/6 and P40, distinguishing it from adenocarcinomas. In HPV-related SCCs, P16 positivity serves as a surrogate marker. Imaging modalities such as CT, MRI, and PET scans assess the tumor extent and metastasis. Treatment varies based on staging. Early-stage SCC is managed with surgical excision or Mohs micrographic surgery for skin SCC. Advanced cases require radiation therapy, chemotherapy, or a combination of both. Platinum-based chemotherapy agents like cisplatin and 5-FU are commonly used. Immunotherapy with checkpoint inhibitors, such as pembrolizumab, anti-PD-1, is now a key option for recurrent or metastatic SCCs. Targeted therapies against EGFR mutations are being explored. Survival rates depend on early detection and treatment. Localized cutaneous SCC has an excellent prognosis, with a 5-year survival rate exceeding 90%. However, metastatic SCC has a poor prognosis, with survival rates dropping below 30%. What worsens the outcomes? High-risk features such as perineural invasion, deep tissue invasion, and poor differentiation worsen outcomes. Preventing SCC starts with UV protection, smoking cessation, and monitoring changes on the skin regularly. For those at high risk, regular screenings can be life-saving. Early intervention significantly improves prognosis, so recognizing the warning signs is crucial. This video is for educational purposes only and should not replace professional medical advice. Subscribe to Science for Fun Academy for more medical content, and don't forget to share this with your peers. Check out our library of full-length lectures, and thanks for watching.